Thank you, Vishal. Thank you very much. Thank you.
Yeah, Udat, the remaining part of your presentation, and I presume that 20 minutes is all that we have. So if you can kindly proceed, and then we can get on to the panel discussion.
Sure.
Anna, I know that I have stolen 15 minutes of yours, but knowing that you're very gracious enough, we'll cover that in the panel discussion. Thank you.
Okay. So to continue from where I left from my morning session, I'm going to be talking a little bit more about the possibilities, protocols of conventional implant dentistry. You saw some of it in the morning, the possibilities with the basal implants, and let's see what we can do with conventional protocols, whether we have some advantages there, whether we have some limitations there. So let's first talk about the possibilities with conventional implant dentistry. The first one to start with is it's quite easy to treat a single tooth in the aesthetic or non-aesthetic zone, which I think is a fairly limited option when it comes to doing basal implants. From whatever I've understood and seen so far, treating unilateral or bilateral edentulous spaces, the typical Kennedy's class 1, class 2 type of situations, which get quite easily treated very predictably with conventional implants. I do understand that there is some amount of limitation when it comes to basal implants in treating these cases predictably in all kinds of situations. Treating fully edentulous arches with fixed restorations is very easily, very predictably possible with conventional implants. Immediately loading very predictably again for teeth in the aesthetic zone, be it a single tooth, few multiple teeth missing in the aesthetic zone with conventional implants, giving really high-end aesthetic results is possible. And of course, extremely predictable, time-tested and evidence-based fully edentulous immediate loading situations are also possible. What is also possible over here, and which is something which I would like to highlight, is the possibility of retaining good teeth in the arches and not needing to extract them simply for cross-arch stabilization. Having the luxury of choice between wanting to immediately load or not, depending upon patient factors, clinician factors. So which means that when you place the implants, be it a full arch, be it a single tooth, we have the luxury as conventional implant dentistry when we are doing two-piece implants. If you feel comfortable about loading it, by all means you can go ahead and load that case. If you feel you do not want, you have an alternative way of giving a provisional restoration, you could bury those implants, come in later and do conventional loading as per the protocols that we have learned over the years. So we have that luxury, which something which the basal implant designs do not have. You're just looking at one-piece implants which need to be loaded come what may. You just don't have a choice over there. Choosing between a flapless or a flapped approach, there's also a lot of hype about basal implants can be put flapless, almost to say that the conventional implants cannot be put flapless, but that's not true. Flapless implant placement is also possible very well with conventional implant placements. Also, this is something which really appeals to me, the ease of retrievability of prosthesis. We are seeing edentulous patients at a much younger age, late 40s, early 50s. We are looking at life expectancy for at least 30, 35 years. And during that period, I'm sure no matter who makes the prosthesis, whether it was made in 72 hours or 72 days, that prosthesis is going to require some maintenance. There's going to be a time, I'm some of y'all who have gone ahead and done basal implants in the last few years. Please tell me if those patients will come back to you, and if you ever need to remove those prostheses, put that hand on your heart and tell me, do you really like that feeling of removing those prostheses, cutting through that metal? Because if you really do feel like, and you really feel that you're going to do that on somebody you really love, somebody you really care for, cut that prosthesis through that 10, 12 abutments. It might take Dr. Ide 20 minutes. I'm not sure it takes all of us over here 20 minutes to cut through 10 or 12 metal units and take that prosthesis out. So retrievability for me is a very, very huge virtue which I can achieve very simply with the conventional implants. Above all, this is the point that I actually want to make, the possibility of retaining good teeth in the arch and not needing to extract them simply for cross-arch stabilization. Now, I want to ask the proponents of basal implants, and particularly Dr. Ide, do you really approve of this kind of a treatment plan? Because I have seen a lot of likes on Facebook, especially from the proponents of basal implants. So I would truly like your opinion on this kind of a treatment plan where almost every single tooth in this arch seems like it can be saved and only the teeth that need to be missing need to be restored. But you can see over here that the entire case has been managed over here by extracting all these teeth and putting basal implants over here. And really, is this what you teach or is this what you learn? I would really like Dr. Ide to ask him, yeah, maybe during your, yeah.
If I accepted, I said not now, no.
Sorry?
In the panel discussion, not no, I rule no, please. Because I am very, very conscious about the time. I'm absolutely clear. This very question will be the first question that I'll put to him during the panel discussion. Don't worry.
Thank you.
Okay. Go on.
And this to me is not dentistry. If somebody is going to defend this, I mean, I really feel there is no debate on the matter anymore. If you're going to debate about extracting this teeth to put those implants over there, I think it is not dentistry at all. So let's move on from here. Go on, and I'm going to show you what's possible with conventional dentistry. Cases like this, which otherwise might seem completely hopeless to you, teeth which you might be very tempted to extract and just put implants all over the place. You don't necessarily need to do that. You can pick and choose some of the teeth which can be salvaged. I can go on putting the implants in the edentulous spaces. I can retain teeth over there for the sake of proprioception, have crowns over it, restore this case beautifully in good function, good occlusion, allow proprioception over there, and I'm sure I'm going to get long-term results for cases like this. I do not ever support the idea of extracting even a handful of teeth for the sake of putting implants. That's just not the kind of dentistry that we want to see in this country, at least. All right? I want to see this kind of thing. Easily manageable, small pieces of restoration. Have a problem with one side of prosthesis, take that out in a matter of few minutes. You want to add an implant, one tooth over here fails in between, extract that tooth, remove two prostheses, make a longer prosthesis. Think about the future. These patients are going to live for 30 years after you've done this rehab. They're not going to live for 5 years unless you are planning to just move your practices in 5 or 10 years. Yeah, but these are the kind of cases that we're going to see. We are going to need to maintain these cases. Make it simple for yourself in future. Make plans so that you have things in small sections which you can easily change and convert from smaller prostheses to bigger prostheses as the case starts getting bigger and bigger for you. Don't plan in future thinking that these teeth are anyway going to fail after 10 years, so just extract them now and go ahead and plan for implant-supported restorations. So that, according to me, is a very, very strong point when it comes to doing conventional implant dentistry. There is a limitation. I'm also going to talk about limitations, and I'm also going to admit over here a lot of things which I continue to do in practice, and I will continue to do that. Right? Is that placing implants in highly resolved maxillas as of now is still a big limitation in conventional implant dentistry, and that's the reason why we have other options of zygoma implants and of course the basal implants, which where Vivek has shown some really good cases. Where he's placed those implants in highly resolved maxillas. So this is one area where I'm willing to understand and even accept, and I'm also willing to tell you that if things are done and taught and explained in the right manner, I'm open to doing something like that in my own practice sometime in future. I'm not saying I'm close to it, and that's the reason why I'm here. I'm not here to ridicule you guys over here. You don't get me wrong on this aspect of it. It's just that unfortunately what has been happening and what I've been seeing are cases where normal, conventional, good routine dentistry is possible, and just for the sake of getting those basal implants in, a lot of unnecessary things are being done, and which is something which has really hurt me, and that's the reason why I'm here, not for really coming and ridiculing the science or science at all. And honestly, Dr. Ide, I must tell you this, when I've been reading, I've been seeing the kind of work that's been put on the social media over here, and the kind of applause that it gets from the local people who are in favor of basal implants. It shocks the hell out of me. But that's when I really decided that I'm going to actually read some of your literature, and I actually borrowed some of the literature, and I went through some of that, and I do feel that you've got a lot of protocols very, very correct. It's just unfortunate that those protocols are not getting trickle down over here into our system. And what we are seeing over here is nothing short of quackery. It is nothing short of quackery is what I'm trying to say. I have read your books, I have seen some of the protocols, and I feel those protocols are extremely, extremely doable. But it's, I don't know what it is, whether it's the teaching or whether it's the understanding of the people over here, but we are not getting it right, and I can assure you that. Yeah? Peri-implantitis is a growing issue, and it will continue to grow. We are going to continue to be bothered with peri-implantitis because of rough surfaces, and we are willing to accept it. I'm not going to shy away and say that, oh, peri-implantitis doesn't happen in our population or in our implants. It happens. It's a concern and we are dealing with it. I think we are getting better and better at it, and it's a matter of time before we'll find a solution for it. But just because peri-implantitis is an issue, you don't go take risks and put basal implants just to avoid peri-implantitis. You know, that's the kind of explanation I get. Our implants don't have peri-implantitis, so put them. I mean, that's not the only reason why you put implants, right? You put implants to restore teeth, not to avoid peri-implantitis. Yeah? One of the biggest advantage of conventional implant dentistry is the amount of complications. The amount of serious complications are minimal. What you see as complications is literally a small percentage of populations. What the number of conventional implants that are probably put worldwide, and if you see the statistical number of real serious complications, is very minuscule. And I can tell you from what I've seen in the morning about doing those lingual bypass or pterygoid implants or whatever it is, I am telling you, no matter what, how skilled you are, there will be a time when you will see those number of complications rising. Okay, and if you are not serious to it right now, we'll come and discuss the same thing again 5 years down the line. Take a note of the number of complications and the number of numb people moving around in our society, and then we'll come and discuss this matter all over. Okay, now for you, if you're still not convinced about what conventional implant dentistry can do for you, this is what I'm going to show you. Just going to show you a series of cases. Just see if this makes any sense to you. I'm going to show you things from single tooth to full arch, one piece to two piece implants, open flap to flapless, and I'm going to show you conventional and immediate loading both. All right, let's start off with a simple case. Lower anterior is missing, and you know what? I love one piece implants. I love them for this situation, and I continue to do that. I've placed a few hundred of these implants for these kind of situations. Anterior teeth missing, lower mobile teeth. I make a wax up of this. I make a stent of it. Index of it. I go ahead, I extract the teeth, I put two implants, I get those implants as parallel as possible. These are one piece implants, right? I get them as parallel as possible. I put impression copings on them. These are transfer copings. I do not take direct round and bridge impressions on them. I will transfer that impression, I'll keep that impression and send it to the laboratory. Meanwhile, what I'm going to do over here, chair side, and this is chair side, is that I'm going to make a provisional and I'm going to fix it immediately over those two implants. So this gets immediately provisionalized. The patient walks out with this situation. The patient comes back to me in about 2 months' time. Meanwhile, the laboratory has gone ahead and fabricated this whole prosthesis in porcelain fused to metal. And as you can see, when the lab transfers happen over here, you get to see the restorative margins correctly. Any good laboratory technician is going to make a nice, really good fitting prosthesis over it. And all you need to do is go ahead and do a cement retained restorations 8 weeks down the line over these two implants. And that's how you end up this case. Really nice, really clean, easy to maintain, and no hassle at all. I love these. These work extremely well for this kind of a situation. So these four lower anteriors replaced with two one-piece implants. And all this in just 2 appointments. So if you are in a hurry or patients are in a hurry, there are solutions. There are solutions. You can do this entire case in just 2 appointments. Another great indication for one-piece implant, which I can't see any other solution, are these congenitally missing lateral incisors. You don't have enough space over there for conventional 2-piece implants. You need a narrow diameter implant which is 2.5 or 3 millimeters in diameter. That's the only way you can do these kind of cases. This is a case, congenitally missing lateral incisors. Orthodontically, we created the space for it. After that, surgically, we go ahead and place the two one-piece implants over there. And obviously, as you can see over here, this one-piece implant needed some preparation, right? This would require some amount of preparation. We go ahead and make some kind of a provisional crown over it. Thereafter, when we have made the impression for this kind of a case, we are able to transfer that, make a model out of it. On the analogs, we are able to trim these analogs over there. We are able to make a jig out of it. This is a preparation jig, which can get transferred from the model exactly into the oral cavity. In the mouth, we are able to duplicate exactly the way the preparation has been done into the mouth. After that, the crown that the laboratory has made is going to very, very snugly fit over there. And that's the kind of emergence, that's the kind of end result that you will achieve in these kind of cases. Now, I can do that if you have 1, 2, or 3 parallel implants. This is what I can't understand. How the hell do you get this right when you have 10, 12 such implants? How do you get that parallelism right? How do you get that prosthesis to fit the margins so well? When it comes to aesthetic zone, anterior teeth, you might say that, yeah, my population does not require high-end aesthetics. I'm from rural areas. All right, if that's the kind of dentistry you want to practice in rural areas, then let's segregate conventional dentistry for urban and basal dentistry for rural. Is that what you want to say, Vivek? Is that what, or you think it's, yeah? It has to be.
I say anything. I didn't say this.
And
But
Vivek,
I'm
no,
telling
no, no,
you,
no.
I'm
Vivek
telling
has
you,
said,
this
Vivek
year-
has said the
this
kind of patients who
year
come
in-
to me
this
are
year
all
in the-
rural.
This year in the Federal Republic of Germany, 1.5 million patients will turn 60. Next year, again, 1.5 million means we need 3 million jaws per day. Who the hell is going to make them? And you want to do it with your technology? You will never be ready. You need millions of dentists, and they are not
We have enough.
available.
We have
No,
enough in our country.
You don't have
We have
them.
enough in our country to manage India as well as Germany.
You must offer dentistry
We have-
also to the people who clean the toilet out
So when
there.
it comes to
They
doing,
also want
when it
to have
comes to doing,
implants.
when it comes to doing these kind of aesthetic cases, I see no other replacement to conventional implant dentistry. You can talk about basal implants over here with the kind of cases that you get over here, and the kind of, and you have patients with all kind of expectations. You don't have patients only who come and tell you, oh, you know what, it's an anterior tooth, we can put everything. We can. I have said that I have not seen those cases, and I am here to tell you what we have not seen. That is, there is. These are kind of cases that I want to. These are.
My dear friends, my dear friends, my dear friends, let me remind all of you all. Indra, 1 minute. Indra, 1 minute. 1 minute. 1 minute. 1 minute. I said 1. I said 1 minute. I said 1 minute. Let me clarify. I said in the morning, do not forget, we are all belonging to the dental fraternity. Let us maintain the dignity of the fraternity. Please understand what I'm saying. If you want things to get out of hand, be my guest. But that is not the purpose. We are here to put across a point and take a point. So please, thank you. Go ahead, Udit.
So what we are looking for are these kind of results, and we do have a population of patients. We have a population of patients who demand this kind of a end result. So we are able to give this, and not necessarily with conventional loading. We are also able to do immediate loading in these kind of cases. So case like this, teeth are extracted, implants are placed immediately, provisional restoration is given on the day of the implant placements, immediately loaded, wait for about 2 months. After 2 months, convert that from a provisional to a really nice looking final restoration with 3 single individual crowns on each of these implants. So that's the kind of easy dentistry, easy kind of solutions that we want for patients, which are going to be very, very predictable and very easy to maintain, and of course highly, highly aesthetic. When you're talking about flapless implant placements, yes, we do flapless implant placements even in.
Kindly respect him, please. Thank you.
When it comes to doing flapless implant placements, routine, simple, straightforward cases, it's quite easy, quite predictable. You have sufficient volume of bone, go ahead, do a flapless implant placement. I have no problems with that at all. It doesn't mean that if you are doing flapless, it can be done only with basals. That's not true. That's somehow the kind of impression that's been created that basal implants can be done flapless, but that's not true. There is also scope for conventional implant dentistry to do flapless placements. Quite predictably, get the impressions maybe on the same day itself, get the laboratory to fabricate your crown, and that's the eventual end result. In this case, a simple cement retained crowns. Again, I don't have an issue with cement retained crowns, provided they are also small spans, single teeth, 2 teeth, 3 teeth, which are quite easy to fabricate, quite easy to cement, quite easy to clean up, and quite easy to maintain. But as the case gets a bit bigger and bigger and goes across the arch and you have full arch prosthesis, I'm far more comfortable doing anything that is retrievable. And really, if you are worried about cement excess, I think this is a fairly good solution. This is something that is quite underutilized in our country. Are the tissue level implants, where you have a nice tall polished collar over there. So if you're really concerned about the tissue excess below the soft tissue and causing bone loss over there, tissue level implants can serve you extremely well, because everything is above the soft tissue. All your restorative margins, everything is above there. Your restoration ends on top of that supragingival area. It's quite easy to clean up all the cement excess, and you're going to have a really nice soft tissue result in the end. Also, keeping the rough part of the implant in the bone and having a slightly taller smooth surface collar which is above the level of the tissue, and having a restoration which is supragingival. So really, for a lot of us for whom cement retained restorations or cement excess in the sulcus is a big issue, this is a fairly good solution for such cases. Also, when it comes to doing flapless, no problem doing even full arch cases such as this, getting the implants in place, all using a flapless approach, and then eventually giving the patient some kind of a screw retained immediate restoration. Hopeless cases like this, I do see a role, of course, in basal implants in cases where there is a lot of resorption. But a lot of these cases, I think can be managed very well, very predictably with conventional implants. Now let's look at this case, a case where you need to do a total extraction. This is a periodontally involved situation. This is how we would go about doing it. We would actually make the prosthesis not after putting the implants, but before we go ahead and put the implants. So we'll first mount the case on an articulator. We would start doing a teeth setup. We would actually make an acrylic shell which is going to serve as a provisional restoration. You're going to go ahead and place those implants, be it flapless, be it with the flap, it really doesn't matter. You get all the implants in place. On the day of the surgery itself, the titanium cylinders are put. A rubber dam is put to cover the wound. Then you have a acrylic shell over there which gets picked up, which picks up all the titanium cylinders with the help of a resin. And once this whole assembly comes out, then either you in the clinic or a lab technician over there can finish the underside of this restoration, get really nice good contours, and go ahead and fix that restoration. And that's not necessary in 72 hours. It can actually be done in just about 3 hours. So it's from the time you put the implants to the restoration in these kind of cases can be managed quite easily in about 3 hours. And you know the beauty of this, that is retrievable, because 2 months down the line when the patient comes back, I don't really need to struggle over there to take that prosthesis out. It's a matter of 5 minutes. I have to unscrew 6 screws over there, and this whole thing can come out over there, and you can reveal a nice good tissue over there with all the implants in place. Now from here on, it's what Rahul showed you some time back. Take good conventional impressions, take a proper jaw relation, get it on the articulator, pick a nice prosthesis of your choice, choose your material, choose your prosthetic design. This one in particular is titanium base with some PEEK and composite resin teeth. The same thing can be done in the maxilla. The lower denture goes in place. Then the maxillary treatment is started. We extract all the teeth. All the teeth have been extracted. After that, we go ahead and place 6 implants. 2 are tilted and the 4 implants are straight. So those 2 tilted implants go in at about 30 degrees. These 4 implants go in as straight as possible. We put some multi-unit abutments over there to change the angulations and try and get them as straight as possible. A denture which has been fabricated is then modified and then picked up. Within a matter of few minutes, the laboratory technician is then able to trim this denture, get into a really nice shape over here, nice convex profile on the underside, and fix that again in a matter of few hours. So again, these kind of cases are possible with conventional dentistry. It's not that these can't be done. And that's how it ends up with 6 implants down and 6 implants up over there. And the beauty of it is again the retrievability factor, which I'm able to take care of quite easily. So even this, when you really take this prosthesis out and see the underside over there, we know that patients don't maintain very well. So the moment you take it out, you're able to clean the underside of it well. You're able to look at the implants, do whatever is necessary quite easily. Let's look at highly resorbed cases. Like I said, the maxilla is quite a limitation, but a lot of cases in the mandible, even in highly resorbed cases like this, is quite possible. Again, we go in using the classical tilted implants concept, get the 2 implants tilted, 2 implants straight, all those to avoid the mental foramen there. Get the multi-unit abutments in place. Again, get the titanium cylinders. Again, get the denture with the holes in it, get the denture in place, put in your resin, pick up the denture. After that, within half an hour, the laboratory technician or your assistant can trim the denture, and within a matter of few minutes, you are going to be able to fit this. Again, retrievability, patient comes back in 3 months, take the denture out, go ahead and make a final prosthesis of your choice. So this is really the type of dentistry that that I like doing. And when it comes to doing upper and lower arch, I don't think that's also an issue. If you have the time, you have the ability to put all those 12 implants in one surgical appointment, you have a good support member in your team who can make that denture for you. It's not impossible to get all those all those implants in and give this patient an upper lower fully fixed restoration in a matter of less than a day. So let's just look at a little video of this. These are all the implants going in. These are all in the maxilla. You can see 6 implants over there. These days with these implant designs, getting primary stability is really not an issue. So you get the titanium cylinders, put in the resin, unscrew this, take it out. The denture then gets modified by the laboratory and you have your maxillary screw retained restoration ready. You see the underside of that prosthesis. The same thing is done in the mandible on the same day. Incision made, implants as parallel as possible, all within the safe zone of anatomy. The multi-unit abutments, the titanium cylinders, the denture modification, the pickup with the resin, and then a little bit of work that needs to be done after the denture has been picked up, just adding some acrylic, trimming off all the excess. And that's what you like to do. You want to see, you want to clean the underside of it, you need to trim the underside, make a nice convex surface over there. So get the screw retain restoration back in place all in a matter of a day. And that's how the case ends up. So I'm going to end this again with few concluding remarks. Thanks. So just these are my thoughts, my beliefs. Edentialism is debilitating. We understand that, and Samir, you made a good point about your grandmother. But let's understand that it's not a disease. Being edentulous is not a disease. All right, it's a situation. It's a handicap. We understand that it's a handicap. So I don't see any reason why it has to be treated so aggressively as though it's a pathology. I don't see any reason why we need to take undue risk in trying to make a patient who is edentulous and give him a set of teeth. So the risk of a complication for an edentulous patient is something that we would like to avoid. We would like to keep everything within a safe zone and minimize the number of complications without causing any risk either to any anatomical structure or maybe even any kind of a fatal complication that is likely to occur while treating these kind of patients. Complications are a part of every surgical treatment. We also face complications. But when I do any case, there's one thing that I always tell myself is, and especially when I'm doing a treatment for, let's say, replacing teeth. I'm not treating a fracture, I'm not removing a cyst, or I'm not treating disease, or I'm not treating cancer. I'm just replacing teeth. So all I want to tell myself when I'm starting a case is that if I do this case and if I land up with a complication or things don't go the right way, at the end of the treatment, I would like the patient to be at the starting point where I started. I do not want that patient to go 1 or 2 steps behind with some kind of a disability or some kind of a complication which is untreatable or irreversible. And this is what I do for every single case, whether it's a single tooth or whether it's a full arch, whether it's a young patient or whether it's an old patient. I do not want to take the patient few steps behind from where we started. I want the patient, even if there's a complication, if there is a complete failure of my treatment, to be at the starting point of the treatment. Yeah. So weighing the risks and benefits is the key really for us to understand in practice. But also everybody said this since morning that they don't come to us for screws, they really come to us for teeth, and that's what we really want to do. So all our efforts should be directed towards making a good functional and durable prosthesis which is easy to maintain, which is based on established prosthetic principles. Yeah? Replacement of teeth with dental implants is an elective procedure. Let's understand that. It is not a life-saving but a life-enhancing procedure. Yeah? As responsible clinicians, the minimum that we can do is at least do no harm. Yeah? I think we've learned this all, that whatever we do is do something. Let's not forget the Hippocratic oath that we take, that let's do no harm, let's try and do things in the safest possible way. And coming back to where I started from, I still feel that there is room for basal implants. I still feel you do not need to come in the way of each other or clash. I still see a lot of hope with the basal implantology technology, particularly in the kind of cases that Vivek showed. Those completely hopeless situations where there is absolutely no chance at all. And I feel there is good enough reason for us to have a path over there where we can have a clear cut, clear-cut indications for where you think basal implants is a much better choice, and a clear-cut indication where conventional implants is a better choice. If you are able
Very
to
well.
come to that kind of an understanding, at the end of the day, I think we would have done ourselves some service. And again, my closing remarks over here would be that let's not dismiss this as a fad, which is what some of us wanted to. But like I said, after having read some of the literature, I do feel there is some place for it. But unfortunately, there is something that is happening over here in our country where the actual essence of what is being taught is being lost, and I do see that at times a lot of wrong treatment is being rendered to patients. So I thank all of you. For some of you who may want to send me some private email or do not want to speak openly about anything, please feel free. Whichever side of the fence you're sitting is, I'm welcome to all kinds of ideas and suggestions. So feel free to send me a mail.